Hello, Doctor. Hello, students. My name is Jorge Angeliza Leon. My topic is Rivaroxaban in patients with heart failure, sinus rotting, and coronary disease. Definition: Rivaroxaban is an oral direct factor XA inhibitor that reduces thrombin generation in doses of 10 to 20 milligrams daily. This agent is approved for a variety of indications, including the treatment and prevention of venous thromboembolisms and the prevention of stroke or systematic embolisms in patients with atrial fibrillation. Lower doses of Rivaroxaban, for example, 2.5 milligrams twice daily in combination with antiplatelet agents, have been found to reduce the risk of death for cardiovascular causes, myocardial infarction, and stroke in patients with acute coronary syndrome or stable coronary artery disease.
Analysis of the Commander-HF study, which had been published just a few months ago. And what we did in this analysis was based on the results in Commander. We recognized that mortality was the main driver of the primary outcome of that study, and that many of the deaths were due to heart failure. However, thromboembolic events still continued in the Commander study, and we felt that there might be a signal for Rivaroxaban favorably affecting those thromboembolic events, so we decided to do a sub-analysis and look at that a little more closely, and that's the basis of what we did. So in the study, we used the Commander population, and just as a reminder, these were all patients that had heart failure with reduced ejection fraction. They had chronic heart failure, but had experienced an episode of worsening and predominantly a heart failure hospitalization. And these were also patients that had evidence of coronary artery disease. They were in normal sinus rhythm, and they were then discharged from the hospital, and within 21 days of discharge they were enrolled in the study and randomized to receive either Rivaroxaban at a dose of 2.5 milligrams twice daily or placebo on top of standard care therapy, and then they were followed at regular intervals through the duration of the study. So this is a post hoc analysis, and we used a composite of events that we felt would represent the thromboembolic risk that this population would be exposed to. So we incorporated myocardial infarction, ischemic stroke, sudden or unwitnessed death, pulmonary embolus, and symptomatic deep venous thrombosis. So this was a composite of those 5 components. The results were a 17% risk reduction, which was significant in favor of Rivaroxaban compared to placebo. During the course of the trial, nearly 15% of patients had experienced one of these events, and Rivaroxaban reduced the risk by 17%. So I think there's some important practical implications. Number one, for many years we had been looking at a possibility that thrombosis was a driver of the poor outcomes in patients who were hospitalized for worsening heart failure. And this clinical trial, Commander, showed that that's not the case. However, patients with atherosclerotic disease continue to have thromboembolic events. And the analysis that was done in this case shows that low-dose Rivaroxaban has a potentially favorable effect in reducing them. That's very similar to what was shown in both the COMPASS study and in the TIMI 51 Atlas ACS2 study, which looked at patients that also had coronary disease. So many of the patients, because there's now an indication for using low-dose Rivaroxaban along with aspirin therapy in patients post-ACS based on the results of the ATLAS study, if they were hospitalized for worsening heart failure, one would keep them on this therapy.
Application in medicine. Previous studies have suggested that inhibition of thrombin generation with Rivaroxaban could be beneficial in patients with heart failure involving patients with a recent acute coronary syndrome. The dose of Rivaroxaban, for example, 2.5 milligrams twice daily, at the background of the dual antiplatelet therapy was associated with a lower likelihood of the primary endpoint of the death for the cardiovascular causes, myocardial infarction and stroke, than placebo. In the cardiovascular outcomes for people using anticoagulation strategies COMPASS trial in patients with stable atherosclerotic disease, the combination of Rivaroxaban 2.5 milligrams twice daily plus aspirin 100 milligrams daily but not Rivaroxaban 5 milligrams twice daily alone was associated with significantly lower rate of the composite outcome of cardiovascular mortality, stroke, or myocardial infarction than aspirin 100 milligrams alone. Along 14 analysis of the subgroup of patients with a history of heart failure who were enrolled in the COMPASS trial suggests that they may benefit from treatments with Rivaroxaban in combination with aspirin. It is also used to prevent serious strokes or blood clots in adults who have atrial fibrillation, a condition in which the heart beats irregularly, making clots more likely to form in the body. Possible causes a stroke. That it is not caused by heart valve disease. Rivaroxaban is also used to prevent DVT and PE in adults who are having hip for knee replacement surgery or in people who are hospitalized for serious illness and are the risk of developing a clot due to decreased blood pressure, ability to move, or other risk factor. Pros: a subgroup analysis from the trial suggesting that patients with a history for heart failure were at the higher risk for the cardiovascular events and derive greater benefit from Rivaroxaban treatment. In patients with stable atherosclerotic disease, the combination of Rivaroxaban 2.5 milligrams twice daily plus aspirin 100 milligrams daily but not Rivaroxaban 5 milligrams twice daily in alone was associated with a significantly lower rate of the composite outcome of cardiovascular mortality, stroke, or myocardial infarction than aspirin 100 milligrams alone. Cons: due to the results of this test, we can affirm that involving patients with a recent acute coronary syndrome, Rivaroxaban 2.5 milligrams twice daily added to the background of the dual antiplatelet therapy was associated with a lower likelihood of the primary endpoint of death from cardiovascular causes, myocardial infarction, or stroke than placebo.
When you feel well and you don't have symptoms, it's hard to imagine that something is going on in your body that may be harmful. We know with heart disease that there is a long asymptomatic period where people don't have any symptoms. While someone might have a heart attack at 70, the coronary artery disease has likely started when they were in their 30s for decades and decades. Unfortunately, there's no symptoms until it's too late and someone's had a heart attack or they have heart failure or they've had a stroke. The majority of people that have high blood pressure don't know it. In addition, high cholesterol, the vast majority of people don't know that, and you have to get a screening blood test in order to detect high cholesterol. The American College of Cardiology and the American Heart Association has a risk calculator for 10-year or lifetime risk of developing cardiovascular disease, and we recommend people talk about that with their doctor. If you lower your blood pressure by 20 millimeters of mercury, you halve your risk of dying from heart disease. If you lower your cholesterol by 50 milligrams per deciliter, you halve your risk of developing coronary artery disease. And if you're a smoker between the ages of 35 and 44, if you quit smoking, on average, you'll expect to live 10 years longer.
Heart disease is still the #1 killer in the U.S., but there are some simple steps to reduce your risk factors. Cardiologists recommend following a few simple healthy lifestyle habits and getting regular screening tests to reduce cardiovascular risk.
By focusing on not smoking, getting regular exercise, eating a good diet, maintaining a healthy weight, and avoiding or treating high blood pressure, high cholesterol, and diabetes. Those 7 things can dramatically reduce the risk of developing heart disease even in people who have the cardiac risk factors.
The use of Rivaroxaban in Ecuador. Local name Xarelto film quap table 10 milligrams blood and the hematopoietic organs. Antithrombin agents, antithrombic agents, direct factor XA inhibitor mechanisms of action. Rivaroxaban is a highly selective direct factor XA inhibitor with oral viability inhibition of factor XA interrupts the in-stream and extrinsic pathways of the blood coagulation cascade inhibition, both thrombin formation and thrombus formation. Rivaroxaban does not inhibit thrombin, activate for factor 2, and the effects of platelets have been demonstrated. Therapeutic indication: prevention of venous thromboembolisms, VTE in adults undergoing selective heat of knee replacement suggests treatment of deep vein thrombosis (DVT) and pulmonary embolisms (PE), and prevention of recurrence of DVT and PE in adults, prevention of stroke and systematic embolisms in adults with not valvular atrial fibrillation, with 1 or more risk factor, HAF, hypertension, age greater than or equal to 75 years, diabetes, previous stroke, or transient ischemic attack. Conclusion. In the conclusion, clinical practice record have documented that the dabigatran, rivaroxaban, and apixaban compared to BKAS are associated with a significant reduction in the index of intracranial hemorrhage, with similar rates of ischemic stroke or systemic embolisms. The selection of OAC depends to the several factors: a product indication, patient characteristics, comorbidities, concomitant medication, physical expectation of patient preference. Thank you.
So I'm here at the European Society of Cardiology Heart Failure, and happy to present as part of the COMPASS team the sub-analysis of the COMPASS heart failure sub-study. Specifically, as we know, COMPASS was a large multi-center, multinational trial which found that use of Rivaroxaban 2.5 milligrams twice a day plus aspirin was superior to aspirin alone in patients with chronic stable coronary artery disease for major adverse cardiac events, net clinical benefit, as well as mortality. In the sub-study, we looked at patients specifically with a clinical diagnosis of heart failure at baseline to see if they had similar effects. Indeed, what we showed is that according to the hazard ratios, the relative risk ratios were very consistent across the spectrum of whether or not the patients had heart failure or did not have heart failure. There was no significant interaction between those with or without heart failure, although interestingly we did see a significant improvement in absolute risk reduction for those patients with heart failure. Patients with heart failure had an absolute risk reduction of use of Rivaroxaban plus aspirin as compared to aspirin of 2.4%, with a number needed to treat of 42. This in comparison to patients without heart failure with an absolute risk reduction of 0.9 and a number needed to treat of 111. If we looked at the safety effects, that is major bleeding, we saw no significant difference between the patients that were treated with heart failure, although there were increases in patients treated with Rivaroxaban plus aspirin as opposed to aspirin. Looking at the net clinical benefit, which weighed the risks and the benefits, the risk of major adverse cardiovascular events and serious bleeding, we showed that Rivaroxaban plus aspirin did have a net clinical benefit very similar to what we had seen with the overall trial, but the absolute risk reduction was again reduced in patients with heart failure as compared to those without heart failure. So in conclusion, we see that the patients with heart failure actually had an increase in overall risk as opposed to those without heart failure, but a very consistent finding with the use of Rivaroxaban plus aspirin as compared to aspirin. We'll be very interested to see with further analyses how the patients compare with preserved ejection fraction versus reduced ejection fraction. And also this will be a nice setup for the upcoming Commander HF trial, which will look specifically at patients with reduced ejection fractions and coronary artery disease with the use of low-dose Rivaroxaban plus aspirin. Thank you.
Thank you.